Thank you so much for joining us today. I want to welcome everyone to the last month of the STS 2023 webinar series. Today's webinar is titled Innovations in Lung Tumor Localization, the latest in bronchoscopy and molecular imaging, brought to you by the Workforce on New Technology. Please note this webinar is being recorded and will be available on the STS website and STS YouTube channel. We invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. And we're really excited to see you in San Antonio. Register now to attend the 2024 STS annual meeting. STS medical students and resident fellow members register for free. Attendees will experience 3 full days of sessions covering the latest research and practice for cardiothoracic surgical professionals of every discipline and at every career level. At this time, I am very pleased to introduce our moderators for this evening, Drs. Lui and Rosenberg. Welcome, and let me turn it over to you.
Hi there, thanks everybody for joining. Really looking forward to today's webinar. My name is Graeme Rosenberg. I'm a thoracic surgeon at Keck School of Medicine in Los Angeles.
And I'm Natalie Lui. I'm a thoracic surgeon at Stanford and vice chair of the Workforce on New Technology. We are very excited to welcome Dr. Reisenauer and Dr. Singhal tonight to talk about innovations in lung tumor localization. I'll have Dr. Rosenberg introduce our first speaker. We are planning to do a short set of question and answers after each talk, and then open it up to more questions at the end. So please keep the questions coming in the Q&A section of Zoom. Thank you so much for being here.
Yeah, thank you, Dr. Lui. I'm excited to introduce Dr. Reisenauer. She's the chair of thoracic surgery at Mayo Clinic in Rochester. She's dual board certified in thoracic surgery and interventional pulmonology, and also is the director of the Innovation Center for Mayo Clinic Department of Surgery. So I'd like everybody to remember to ask questions in the Q&A. I'll also be looking at the chat, and I'll let you take it away, Dr. Reisenauer.
Thanks so much for the opportunity to be a part of this webinar. I'd like to thank the STS for this opportunity, as well as Drs. Rosenberg and Lui for asking me to be a part of this. Let me just move this to presentation mode, and hopefully everybody can see my screen sufficiently. So thanks again. I've been asked to talk about transbronchial dye marking for pulmonary nodules. These are my disclosures. So, like anything, when it comes to bronchoscopic intervention, we're often compared to CT as the gold standard. And that holds true, I think, as well for bronchoscopic localization. Just like when bronchoscopic biopsy came along robotically and it was compared to CT-guided biopsy, the same holds true for bronchoscopic localization. And so what is the gold standard for CT-guided localization? In our institution, we've been employing CT-guided radiotracer injection since 2006, and this was actually published in the Annals of Thoracic Surgery in a limited series in 2006. What patients undergo is under conscious sedation. They have a limited chest CT. They come in the morning of surgery early to the CT scanner, and our interventional radiologist then place a 20-gauge coaxial needle into the lesion, and through that place a 22-gauge spinal needle. Through that, 0.1 milliliters of technetium-99 microaggregated albumin is administered, and shortly thereafter, the patients proceed to a post-procedure scintigram. This was initially reported in 46 patients with very good localization success in 96%, and 2 had pleural spillage, but this was, again, fairly early in our experience and in our series. And what it looks like is the following. When the surgeons go to the operating room, they have a visualization of exactly where the needle was, relationship to in relationship to the nodule. As you know, with significant nodule motion near the diaphragm, sometimes the radiologists end up cheating slightly medially or laterally or superiorly. So these images are helpful to guide us in the operating room. And then the scintigraphy image here just reassures that the dye stays confined to the nodule and hasn't spilled into the pleural space. And in situations where that has happened, you either have to go based upon palpation at that point and best gas, or you can try to reattempt injection after about 6 hours, which is the generalized half-life of technetium-99. So what I'm here to talk about today is marking with bronchoscopy and how is that different. So in our practice, we use a combination of ICG and methylene blue. And for those that have used superdimension or EMN-based manual navigation in the past, there's a trade-off between using ICG and methylene blue. So methylene blue is great if your lesion is very pleural and you can see it, but for deeper lesions, the methylene blue is very difficult to detect. And that's why we use the ICG. In terms of the doses, it's very variable. For something that's very, again, subpleural, I tend to use half a cc of methylene blue and 0.25 cc's of ICG. And the more central and the more deep the lesion is, I might go up a little bit and use 1 cc of methylene blue and half a cc of ICG. This is deployed through either a 21 or a 19 gauge needle, and marking can be done either with 2D fluoro, cone beam CT, or mobile 3D imaging. And I'll show some cases here in terms of what imaging modality I would use based on what the nodule looks like. So all of our dye marking is done with robotic bronchoscopy. Hopefully I can get this video. Oh, it's not going to work. So all of our dye marking is done with robotic bronchoscopy. I find that this is really the best tool to really drive out to these lesions and be able to mark them sufficiently. So again, for those that are unfamiliar with robotic bronchoscopy, this requires a pre-procedural CT, which is imported into a planning laptop. A 3D airway navigation plan is generated, much like a GPS. And then you have a live view so you can track your progress at all time and your navigation through the airway. For those that have only 2D fluoroscopy for dye marking, it can be done. And to be honest with you, I think for most lesions where you think you can see it under 2D fluoroscopy, or in upper lobe lesions where there's not as much nodule motion or CT to body divergence, 2D fluoroscopy is very sufficient. You don't need a big fancy cone beam CT just for dye marking. And so a lot of times what I'll do, this is a biopsy case, but in many times I'll drive out to the lesion. The robotic platform gives you this optimal fluoro angle. I'll rotate the C-arm to that optimal fluoro angle and magnify up and see if we can see exactly where that lesion is under visualization. If I do, then I take a couple of agitations with a 21 gauge needle just to puncture through the airway wall and puncture into or right next to that nodule. Otherwise, you're just going to have the dye spill back into the airway. So about 3 to 4 agitations, just as if you were doing a biopsy. And then after you do that, pass the needle out. I pre-mix the dye into just 1 3 cc syringe, so it's all drawn up on the back table, and then just inject the dye directly into the needle. Once the dye is injected, I then instill a few puffs, a few syringefuls of air, just to push all the dye through, and then reinstill the stylet through the catheter to push any dye that's hung up in the channel out into the nodule, and then remove the entire unit. For lesions that are really deep in the costophrenic sulcus, like this one, or lesions that are really deep in the right lower lobe, those might be worth considering fixed cone beam CT or mobile 3D imaging. This is a lesion that we localize with fixed cone beam CT imaging because we had access to the room that day and availability, so we listed the case in there. And again, here you can see we've driven all the way out to where we believe the lesion is virtually. And again, because this is a tiny lesion, a 4 millimeter lesion, we go ahead and perform cone beam CT to visualize exactly where the lesion is. And then under direct visualization, you can instill that 21 gauge needle, which is what we're doing here. Doing a few agitations again with the needle to really make sure you're puncturing through the airway, and then injecting that pre-mixed constellation. of dye. This is our cone beam CT room. So you can see we've injected methylene blue in this lesion and ICG as well. I put both into both lesions, or every time into every lesion, unless the patient has an allergy, because you never know which one's going to show up and which one's not. And we've never not been able to see a lesion when we use both. So we oftentimes just inject both. And then here you can see we've resected the lesion, and you can see our dye is in very close proximity to that lesion. So with the advent of mobile 3D imaging, this has really changed the landscape, because now you don't need a super expensive, hard to get into fixed cone beam CT room to be able to have advanced imaging in those lesions that are slightly more difficult to localize. So here's just a screenshot of a patient where we've got the catheter, we've got the needle, we've localized, and we're doing a spin with the CT. This is done with the patient with a breath hold, typically to a Valsalva of about 20 millimeters of mercury. And then you get an image that looks like this. So here's the lesion. You can see it in 3 different axes, and then you can see the needle going right into the lesion on 3 different axes. The nice thing about localization is that you don't have to be perfect. You just have to be close. And so this was actually a biopsy case. That's why we elected to spin here. But if this was a localization case, I mean, you're slam dunk right in the middle of the lesion. The mobile 3D imaging systems are nice because they do speak directly with the robotic platforms, such that you can tell the catheter exactly where you are. You can then tell the system exactly where the lesion is. And then the system updates such that you can see where the lesion previously was thought to be based on pre-procedural imaging, and where the lesion is now in real time and space. And this is important, particularly in the right lower lobe, because of the phenomenon called CT to body divergence. So many times you think the lesion is going to be somewhere, you put the patient under anesthesia, and within 20 to 30 minutes, you have a decrease in functional residual capacity, the lung gets all autolactatic, and the nodule has moved to a completely different location. And if you end up localizing based on where you thought it was on the pre-procedural CT, there can oftentimes be a good 2 to 3 centimeter movement between that and where the nodule has now migrated to under general anesthesia. And that can have significant implications if you localize in the wrong spot. So the right lower lobe in particular is one location where, if it's a tiny nodule that you don't think you can palpate, doing that under good CT visualization might be something to consider. And if not done bronchoscopically, that's another great one for CT guided localization, to be honest with you. So again, we presented our series. This was very early on in 2021 when we first started doing dye marking with the robotic system. 8 nodules, the majority here again in the right lower lobe, which is where we use CBCT, and then others in the right upper lobe and 1 in the left lower lobe. The median size of the lesions were 11 millimeters, with about 9 airway generations for the median distance to the pleura being 1.5 millimeters. So median radiation dose is very low. The average fluoro time was 2 minutes, again, implying that this is something that should be done quickly and easily. It's done in the operating room when the patient is asleep. So we bring the patients to the OR, we intubate with a single lumen tube, we navigate out, we dye mark, and then if we're anticipating just doing a wedge resection or something straightforward, we just put down a blocker and turn the patient on their side and go ahead and start with the surgery. Surgery can be done obviously thoracoscopically with a fluorescent detectable camera, or with the Da Vinci system with the Firefly mode enabled to see the ICG, and regular white light imaging to see the methylene blue. Others have since published their outcomes with robotic assisted dye marking with cone beam CT. This was another paper that was published in 2022. Again, a small case series here of only 5 cases, but again, very, very, very small lesions, right? 3 millimeters to 10 millimeters in size. And again, I think the important thing to note here is that the localization success rate was very good, despite having very small lesions, and the needle tip to the lesion distance was actually fairly close as well, because again, you don't need to be right in the lesion, you just need to be close. Since then, there are different manipulations and different cocktails, so to speak, of how people have chosen to localize as the technique has evolved. This is Dr. Ng's paper that was written up also in 2022 in Frontiers, and again a small case series. But he uses a triple dye technique, so again similar to what we do with ICG and methylene blue, but also builds in iodinated contrast into this. And the reason for doing so is that when he is driving out with electromagnetic navigation, this is not with the robot, but driving out with electromagnetic navigation and placing the dye, he can be sure that the dye is right next to the nodule. The last kind of interesting development is marking with ICG fiducials, and this is again a case series that was published with 2 hospitals as a proof of concept in 4 patients. But it's an interesting one. Here they took embolization coils, 7 millimeters in size, and they soaked it in ICG for 10 minutes. And then this was backed into a superdimension delivery catheter. Robotic assisted bronchoscopy was used to navigate out to the lesion. And then through the catheter, the superdimension delivery catheter was deployed, and the coil was deployed that you can see here on fluoroscopy. The interesting thing about this, though, is that it was placed up to 9 days prior to surgery, which is a clear advantage over the other localization techniques that have to be done the day of the procedure. It could be done with cone beam CT or 3D fluoroscopy. And then here's the nodule that was detected with Da Vinci with the Firefly mode enabled. So again, one of the advantages to this sort of a system is that if the patient undergoes a biopsy, the fiducial can be deployed at the same time, and it lasts up to 9 days prior to the surgery. So our experience with imaging systems and single stage and localization and all of those sorts of things, we still use conventional 2D fluoroscopy for upper lobe lesions where we don't anticipate a ton of CT to body divergence, or lesions that we expect to see on fluoroscopy alone. Because again, for localization, it's not about getting into the needle or getting into the nodule, it's just about getting very close. Again, even though this is a little bit outside the scope of this talk, for kind of most routine biopsies or for localizing in the right lower lobe where we anticipate a lot of motion, we might consider using 3D mobile imaging. And I really reserve fixed 3D imaging for therapeutic cases like ablation or some sort of injection, or if we're doing the single stage, single anesthetic biopsy staging and resection cases. So what can bronchoscopic localization do? It can allow for biopsy localization and potential surgical resection, and obviously surgical resection simultaneously. It reduces the need for additional pre-surgical procedures, so patients don't have to travel to a CT scanner or go get an infusion the day prior or go do something else. It can be done in the same OR under the same anesthetic by the same surgical team, and doesn't require all this coordination. The learning curve is very easy, 10 cases, and I would say most people are comfortable to at least go after the more straightforward cases that are not in the right lower lobe. It's also a billable procedure that thoracic surgeons can use as a localization procedure when they do their billing and their coding. What bronchoscopic localization cannot do, however, is it's not sensitive for malignancy. The dye is going to go where you tell it to go, regardless of if it's a granuloma or a malignancy. It's not sensitive for occult disease. So if there's multiple other nodules that are suspicious on the CT scan, again, the dye is only going to go where the operator tells it to go. And to that point, if you've got significant CT to body divergence, or the nodule has moved due to body divergence, or you messed up your navigation pathway and you're not sure where you are, the dye is going to go where the operator tells it to go. So those are kind of the downsides of bronchoscopic localization. And then lastly, it doesn't delineate margins either. And if you're a few millimeters off, there's still value if in doing a thorough exploration and trying to see if you can see any subtle signs of a nodule where you do your localization. And so in conclusion, bronchoscopic localization is safe, it's feasible, it's a very straightforward adoptable technique with a fairly straightforward low learning curve. But on the other hand, it lacks sensitivity for malignancy and it's very operator dependent. And everybody on this call knows the implications of a poor localization in a patient with a suboptimal nodule that's not easy to palpate. And so it's my belief that future innovation might mitigate the need for any sort of localization that requires a separate procedure or a separate technique. And I don't think that innovation is that far away. I think it's about 2 minutes away with the next speaker. So we'll stay tuned and we'll see how things continue to develop. Um, I think that's all for me. Thanks so much. It was a pleasure, and thank you again to the STS.
Thank you so much, Dr. Reisenauer. That was great. It's a really excellent, overview of what is an emerging field and a lot of implications for thoracic surgeons and the interventional pulmonology group. There's one question in the chat, which I think you answered, was how many hours before you inject? Is it the day before, or what's your window of time after your injections with the methylene blue and the ICG?
That's a good question. I mean, usually we do it right before we flip them over, so it's within an hour of injection. Now, we have had some cases where, for whatever reason, there's been a delay in flipping and prepping and positioning, and you take the lymph nodes and all that sort of stuff, and it's a couple of hours for whatever reason, and you can still see the ICG and the methylene blue. I think the thing to be careful about, though, is you don't want to create too much hemostasis when you're doing your surgical exploration and visualization, because ICG will travel into any area of bleeding. So if you tear that parenchyma, for example, as you're doing your staple line, that ICG will bleed into that, and then you'll just see a big blob of green, and it's really hard to see and detect. So what some situations, what we'll do, especially if it's a difficult to get to nodule, like something way back in the posteromedial basilar segment, is where we see the ICG and the methylene blue, you might want to cauterize that area so you know where it is and you can go back to it.
Yeah, that's smart. I had a question regarding to lesions that you choose to localize. Is there a characteristic lesion that you find localization most helpful, be it small in a certain location? Do you localize all lesions that you are approaching? What's your approach there?
Yeah, that's a good question. It's a tougher one to answer because I don't know that I have hard and fast objective criteria, but I think in general, if it's something that's going to be obviously visual and palpable thoracoscopically, maybe you don't need to localize that lesion. But I do think we've all been in that scenario before where you think you're going to see it and you think you can feel it and you get in there and you can't. So I think if there's any question that you're going to struggle to localize, or you're going to struggle to manually palpate it or visualize it or identify it, it just makes sense to localize. And particularly when you're talking about segmentectomy, I think localization makes a lot of sense because it's helpful for you as you're dissecting out your parenchymal margin to know kind of exactly where that lesion is in relationship to the parenchyma, especially in these kind of ground glass or part ground glass lesions. So more so than knowing which ones I avoid localizations, I know the ones that I absolutely will localize, and it's those.
Great. My other question, I do invite people out there to add questions to the Q&A or the chat, and we can get back to them towards the end. But my next question would be for thoracic surgeons out there who want to get involved with more experience. What's the best way to go about that? And how do you manage your relationship with an interventional pulmonology group as you're pursuing this as part of your practice?
Yeah, that's a great question. I mean, I'm personally of the belief that the more people learn this technology, it just lifts all boats and it creates better volumes and it allows for better patient care. I don't think it's something that has to be siloed. I mean, I hear thoracic surgeons all the time say, "Oh, well, I just want to do the localization. I don't want to learn the biopsy." And I'm like, "Well, you've already got a needle in the thing, I mean, it's like one more step. You can learn how to do both." And I think the future will quickly come where that's going to be employed more and more and more in the realm of therapeutics. So, my personal opinion is it's great if people are enthusiastic and engaged and want to learn more about how to do it. There's definitely courses out there that help teach and train. And I think a collaborative, multidisciplinary relationship is critical to advancing these techniques and learning more about how this is going to play a bigger role in lung cancer care.
Dr. Rosenberg, can I ask a quick question?
Yeah, please
Yeah.
do.
So Dr. Reisenauer, that was great talk. I have a question for you. We're trying to do this, and we have a practical question. If we inject preoperatively with the or in the OR with with the cone beam and the bronchoscopic technique, we have to do it on a bed that doesn't flex. Because we don't have the ability to, we don't have a bed that flex that we can use in the hybrid OR.
Correct.
So what do you do after you're done? Like, how do you flex the bed, or do you not? Do you do cases?
We don't flex the bed. And that was a change. That was a little bit of a learning curve. So the challenge is if you're going to do that, BMI comes into effect. So it's much harder to do a resection in a patient with a BMI of 40, for example. So patient selection for those sorts of things are important. And if it is one of those patients where you really feel like you need to flex the bed, that's where you might just have to succumb to 2D fluoro and doing it in your regular OR in a regular bed where you can flex the bed. Otherwise, we do the single stage pathway where we do biopsy staging and resection in our hybrid OR, 1 to 2 days a week, and we just don't flex the bed. What we do is we use pillows and bombs and various other things to kind of open up the thoracic cavity. So it's a little bit of a learning curve there too, no question.
So do you do the bumps and the wedge before you start the bronch? I know this is a sort of a practical question, but we're going through this right now. Do you do that before you do the injection, or you do the injection, then you lift the patient up while they're asleep, you slip in the wedge?
Yes, the latter. So the localization is done supine, and then we move them into the decubitus position and put in the bumps and the arm board and that sort of thing.
Great, thanks.
I don't think I realized during your talk that you were doing biopsy, localization, resection all in one day.
Yes.
Yeah, that's great. How do you facilitate the pathologic analysis of that in an efficient way?
Yeah, that's a great question. So in our workflow, and we didn't create it overnight. It took some time, but we do have a cytotech that comes to the room. We have designated, we do it on either Mondays or Tuesdays. So the cytotechnologist comes to the room. We have a mobile microscope with a mobile cart. They come to the room, they stain all the images, they look at it under the microscope, and then the pathologist is able to zoom into the same microscope. We have a robotic microscope that they're able to zoom into and provide an overread for the diagnosis.
That's incredible.
And what cameras are you using to look at ICG?
Yeah, that's a great question. The Stryker 1688 is something that we have available to us. The Storz Rabina system is also one that we have available to us, and then the Olympus system. We have all three. So whatever is available and sterilized and given to me by my assistant is what I use that day. And for the purposes of ICG, the 1688 and the Olympus system seem to be fine. So
great. All right, well, we'll move to our next speaker, Dr. Sunil Singhal. He is a professor and chief of the Division of Thoracic Surgery at the University of Pennsylvania, and also the vice chair of translational research in the Department of Surgery. He has been doing research in molecular imaging for decades now and a leader in our field. So I am very excited to hear the latest in tumor localization using molecular imaging. Thank you so much, Dr. Singhal.
Lou, thank you for that introduction. Thank you to everybody, Dr. Rosenberg and the STS Workplace, a new technology for this invitation. So I'm going to talk a little bit about a different angle towards pulmonary nodule localization during cases. I have no disclosures. So what is the problem? This is the problem. You have a solitary pulmonary nodule. You have a ground glass opacity is one of many. It's a pretty common issue these days. 250,000 lung nodules each year get referred to a thoracic surgeon. And many of us find ourselves in these situations. We've made a port and we're trying to search around and find that ground glass opacity. As we just heard, there's some localization methods, but it's pretty hard to find these nodules with just a single finger palpation. In fact, conversion to open thoracotomy has been touted to be as high as 55%. Now, this is a couple of decades ago data, but it gives you the gravity of the problem that many times you just need to make a bigger incision to get at least 2 fingers in, or to have even a couple digits in so that you can lift up the wet lobe to begin to search for it. And the data has shown that if a nodule is less than 10 millimeters in diameter, or it's greater than half a centimeter from the pleural surface, you're more likely to convert to some sort of bigger incision so you can help localize the nodule. And this is the basic issue that we have to use our hands and eyes to begin to localize this. And as we just heard, there's many different options for how we can begin to localize these. We've talked about needle localization preoperatively in previous discussions. They have their pluses, such as the ability to do it before surgery, doesn't take up time of the OR. It can be done down in radiology. The disadvantages, of course, is the needle can move, especially when the lung deflates, and there's always risks of losing the needle. There's other ways preoperatively. You can send the patient down for dialocalization, whether you go down to the IP suite, do it bronchoscopically. And then there's other intraoperative methods. We've talked about ultrasound previously. There's papers on that. There's IVATs, which the Brigham Group has talked about in the past. And then as we just heard, there's very bronchoscopic techniques. But really what I want to focus on today is this concept of intraoperative molecular imaging, and spend the next 15 minutes talking about what is intraoperative molecular imaging, how do you do it, and what's the current state of the art of the field. So what is the idea behind intraoperative molecular imaging, or IMI, which I'll refer to? So essentially what we are doing is we're visually enhancing a nodule. So you have a nodule, you're visually enhancing it by giving a contrast agent to the patient that goes to the tumor and essentially is making the tumor glow. So it's an intravenous injection of a contrast agent. And there's a lot of advantages of having this approach. The first is there's no ionizing radiation, so there's no risk to the surgeon. There's no need to wear lead during the case. The second, you actually don't need to know what the tumor is a priori, so you don't have to have you don't need to have a CAT scan maybe the day of, or you don't need to have an intraoperative CAT scan. You just inject it intravenously and it will systemically go to where the tumor is located. Third, it's very intuitive. You essentially inject the tracer, you see the lobe or the segment or whatever you're working on, and the tumor will be fluorescing. It's real time, so there's no delay, and it's very quickly scalable. So you don't need a tremendous amount of the new machines to make this happen. So it really is quite quickly scalable. So what is the basics? So what do you need to start an IMI program? So first, you need a fluorescent contrast agent. You need the agent that you inject in the patient. And two, you need a camera to visualize the fluorescence on the backdrop of the white light. So I'll give you an example of what I mean. So first, you need the contrast agent. So this is a typical patient. They come in, they get their contrast agent, even in the pre-op holding area, or depending on the tracer, sometimes even the day before, depending on the various tracers. And then you need a camera. Most of the dyes or contrast agents we're talking about fluoresce in the near infrared range, similar to ICG, where they are not visible to the human eye, because the human eye cutoff is around 700 nanometers, but these dyes are beyond the scope of the human eye. So you do need a camera to visually enhance it. So you typically will have either an Olympus or a Karl Storz or a Stryker or Da Vinci or something to enhance the image. So let's focus, for the majority of this talk, I actually don't want to focus on the camera. That's a whole separate discussion in itself, but I want to focus on the contrast agents. So right now, I want to talk during this talk about 4 potential contrast agents. the Cytolox, which is the FDA-approved contrast agent for lung cancer. We'll talk a little bit about Tumor Glow, which is for metastasectomies. And then in terms of experimental agents, we're not FDA approved. I'm just going to say a slide on them is our EGFR targeted and our cathepsin targeted contrast agents. So a little bit, the majority of the talk, we're going to focus on Cytolox or papilocyanine for lung cancer. And so how does papilocyanine, how does this contrast agent work? So essentially you have a lung cancer cell and it has a receptor for folate receptor. Folate receptor is highly expressed on many lung cancer cells, the majority of which are lung adenocarcinomas, ground glass opacities. And the way it works is there is a folate ligand, which is attached to a fluorophore. It's a very simple concept. You just take plain old folate that we all eat when we have eggs, and you attach it to a fluorophore, which fluoresces. And the moment that you turn on you inject it systemically, it goes to the cancer cell. And when you turn on the lights or excite it, the tumor, it will start fluorescing. So I'll give you a quick example of this. This is a patient with right below ground glass opacity with quite a bit of solid component. And here on the left, you would see the white light image. So you know roughly it's in the apex. When you begin to look on the right side, you can begin to see, as you get a little bit closer, the location of the, it's more of a mass than a nodule, but you get a sense of where the lesion is located. And you can begin to compare it to the surrounding tissues. So this was injected systemically into the patient, went to the lesion. You cannot see it with your eyes alone, but you do need a near-infrared camera. So here you can see on the back table after you've removed it, you can see it's real time. There's no delay in images, and it's pretty precise in terms of the borders of the nodule. I'll give you another quick example. This is a patient with a ground glass opacity. This patient had a previous lesion here. They had a pretty small ground glass opacity. This woman in particular, we usually, to be honest, wouldn't be going after a 6mm ground glass opacity. She was extraordinarily anxious because she had had a previous lung cancer and her mom died of lung cancer. And so she wanted this out. So we talked about potentially doing a wedge. And this is a tough case because you know when you get in there, you're going to have a hard time finding this small lesion. And here you can see on the left, this is the white light image. You've put your scope in, the non-smoker, nice pink lungs, but not obvious where the lesion is. So on the right-hand side, the patient again was injected with a tracer. Notice, by the way, the reflection off the rib. Some of the near-infrared cameras do have some reflection, but as you get a little bit closer to the area where you're trying to pinpoint, you see the nodule there. Now notice along the vessels, there is some overflow out of the capillaries, but for the most part, you can very quickly localize where this lesion is located. So once you wedge it, one of the advantages of this localization method is you don't really need to wait for a frozen. You can immediately on the right-hand side see where the nodule is. You can put a ruler next to it and measure your margin right then and there and proceed to even potentially close the patient if you're only going to do a wedge because you have pretty good confidence that the precision of the borders, because again, the tracer is only being taken up by the cancer cells. So the edge of the tumor is going to be, within fractions of a millimeter of where the tumor ends, where the cancer cells exist. Now, this one we did send for a frozen section because we do follow the standard of care. This was not part of a clinical trial initially. And one of the problems, of course, is that the pathologists have a hard time calling these small 6mm nodules. But you can have a little bit more confidence that since it's a targeted tracer, that on the final pathology, this was going to be a mucinous, well-differentiated, only a 5mm adenocarcinoma, and as predicted by the imaging, a negative margin. So this is a fantastic technology for ground glass opacities. The size of the tumor is not important. People ask, how small of a nodule can you see? It's pretty precise because, again, it's targeted. In laboratory conditions, you can get down to 10,000 cells. So you can see pretty small nodules. The main limiting factor is the depth of penetration. I'll talk to you about that in a second. You can actually increase or decrease the fluorescence just by playing with the gain and the laser power. So that's another benefit. And the angle of the camera matters tremendously. So one of the key things about this is you do need to manipulate the lung a little bit so that you're hitting the nodule straight on. Otherwise, the laser will reflect off the surface of the lung. So in general, when we think about localizing, it's very good for confirming primary disease. In fact, we've actually started to try something different. We just put one port in for these cases. We localize it, and then we'll make a second port right above the nodule. Once we've localized it, put our fingers in, confirm, put the stapler in through the same port that we have the camera, and we just do the whole operation through 2 ports. So it's made our operation even much more precise. So I'm going to talk very quickly about both our pilot study, our phase 2, and our phase 3. And I'm just going to hit some highlights. I'm not going to go into all the details, but I do want to give some key learning points from these 3 studies. So our pilot study was very simple. It was for 21 ground glass opacities in 20 patients. The papillostymine accumulated in 20 of the 21 nodules. Now, when the surgeon used white light only, the surgeon was only able to find 10 nodules. By then switching the overlay on to fluorescence, the surgeons found an additional 5 nodules. And here's an example. On the left, you can see this is a nodule that looks very close to the fissure. On the right-hand side, there is no visible white light puckering of the surface. There's nothing that would give this nodule away. But as you can see, once you turn on the fluorescence, you see it there right around 6 o'clock. The tumor is fluorescing. Here's another example. This is a CAT scan on a middle lobe lesion. Not very easy to see. On the left, bottom left, again, you can kind of begin to see what may be some white density right there by the endokidney. But when you turn on the fluorescence, you really get a full extent of where the lesion is located. Here's another example. This is a much deeper lesion. It's not near a fissure. It's not near the surface, PET positive. On the left, you can see the white light image. And I just wanted to show this. This is the near infrared image. So you can't see it. So this is important so you can understand that it's not going to be perfect for the deeper lesions that don't have, you're talking about 2-3 centimeters deep from the surface. And when we do take it out and you cut it, on the white light, again, you can see the nodule, but when you turn on the fluorescence, the target did arrive at the nodule. It's just you couldn't see it because it was too deep. And that's the Achilles heel of everything we're talking about. In our initial small study of 21 patients, the focus on the 4 yellow dots, those were patients that were only discovered by near-infrared imaging. And as you can see, as predicted, it's best for nodules that are small, less than 1 centimeter, because if they're bigger nodules, you're going to be able to find it maybe potentially with your hands, your fingers, your eyes, or finger palpation. And it's best for nodules less than 1 centimeter from the surface, because that's where you really get the best. The subpleural ground glass opacities was the best ones that were only discovered by near-infrared imaging. This subsequently led to a phase 2 trial, and I'll just to summarize in one slide what we found. This was 5 sites. It was a non-randomized trial, and IMI localized in these 5 sites 11 lesions that the surgeon could not find. So it was about a 12% improvement on just using white light alone. Eventually, this went to a phase 3 trial. This was the Elucidate trial. This was presented a couple of years ago, and essentially the way the trial was done, patients were given the papillostymine. By the way, the tracer is given anywhere from 1 to 24 hours before surgery, depending on the workflow. At our institution, we tend to give it the day before. It just makes our workflow easier. The patient comes in, they get their infusion, and then the day of surgery, you can just clip along and don't have to wait for the infusion center or the suite to open up so the patient can come in and get the infusion. So we just simplified our life and gave the infusions the day before. For patients who come far away, this isn't always practical, so you can do it the morning of and then just make it your third case. You do want to give a little bit of time between the infusion and when you image, because the images get crisper over time. So the patients were then all got the tracer in the study, and they all got white light and palpation as per the standard of care. And then they got randomized to either turning the camera on or not being turned on. This was directed to us by the FDA so that each patient would act as their own control. This was a multi-institutional study across the United States in this phase 3 clinical trial. And here are the sites that the team that put this study together. And the endpoint that we were specifically looking at for localization was the frequency of times that IMI identified the nodule that we were going after, the primary lung nodule, that was not detected under normal light and or finger palpation, depending on the technique of the surgeon, using whatever method they wanted. They were not allowed to use other localization techniques. They were just going to use white light visualization and or finger palpation if that's what they typically used. There were really minimal infusion-related reactions. The main one would be nausea during the infusion, and if the way we usually did it was we just slowed down the infusion. 4 people didn't finish the infusion, but there were no serious adverse events and nothing that required us to cancel the surgery. So in the study, again, the randomized study, there were 19% of the patients who had a situation where the surgeon could not find the nodule using whatever technique they wanted, and yet when they used the intraoperative molecular imaging contrast agent, they were able to locate the nodule. This tracer is now FDA approved, so you can just order it through a pharmacy. Right now, there's only one available camera, the Stryker 1788, which is the only camera that can visualize this particular contrast agent. So I'm going to switch very quickly to another approach. This is not for lung cancer. This is for pulmonary nodules that are for doing metastectomies. These are for sarcomas and colon. This is just plain old ICG. It is a dye given systemically, non-intratumoral, so you give it to the patient. This was a high-dose ICG, so we give anywhere from 2 to 5 milligrams per kilo, and you can give it the day before surgery. 2 milligrams per kilo is the FDA-approved dose, and we'll talk a little bit about the higher doses in a second, but we give it actually the day before surgery. You can use any ICG-compatible camera, either the Stryker, Karl Storz, Da Vinci, and we did our initial pilot study was 30 patients. These were people who had a history of peripheral sarcoma. Similar study has been done with colon cancer, and they all got a 1 millimeter fine cut chest CT. And here's an example. This is a 39-year-old. She has a singular small lesion in the lingula, and you can see it right there. It's a really tiny lesion. And if you can look at her body habitus, you can imagine that this is going to be a hard lesion to locate. So there's a ring forceps, which is nice to know. It's a centimeter from edge to edge. And there, right there, as you turn on the fluorescence, I don't remember which camera this is, you can begin to see the nodule. So this is clearly a sub-centimeter pulmonary nodule that you can localize with ICG given the day before surgery at high dose. And here you can see, there's my thumbs, give you a sense of size, the nodule as we flip between white light and near infrared on the back table. So one size doesn't fit all, so there's a lot of work going on to the ideal dosing. The bottom 2 panels are the 1 and 2 milligram per kilo doses the day before. But there's some evidence that even for the more subtler cancers, you have to go to a higher dose, but that right now is more investigational. A 5-year retrospective study has been done and shown that there's a survival advantage for patients who get intraoperative molecular imaging for metastasectomy, especially because they find sacranous lesions and doing this technique. I want to talk really quickly about two more. Now, this is switching to experimental, so these are not FDA approved. One of them is from our very own Dr. Liu, so the moderator for this. She's working on an epidermal growth factor receptor antibody. She's attached that to a near-infrared dye, and she's currently conducting a phase 1/2 clinical trial at Stanford, looking at localization using this. So there's a number of approaches that can be taken as long as you have a targeted agent for lung cancer. And then this is this is a phase 2B trial that's ongoing, including at Mayo Clinic, which is a VGT309, which binds cathepsin, which is highly upregulated in lung cancer. The tracer by itself does not fluoresce, so it has something called a quencher molecule. It has an ICG attached to a quencher, so the quencher cancels out the ICG. It goes to the cancer, and when the cancer is exposed to it, it takes away the cathepsin, and it chews up the quencher goes away, and then the tumor starts fluorescing. So to conclude, so localization of pulmonary nodules we're talking about today is challenging. There's multiple techniques. The concept of intraoperative molecular imaging, or IMI, is injecting a patient with a fluorescent contrast agent before surgery. Then you image the cancer with a specialized near-infrared camera during the operation procedure. So again, thank you for the invitation, and I also open to questions.
Thank you, Dr. Singhal. I'll start. Can you tell us some more of the logistics about getting started with this new FDA-approved agent? Is the camera available? How much does it cost? What would you recommend?
So the contrast agent, you can just contact the company, and they work with pharmacy to get it in. I don't know if the same price in every institution. I think, is it okay for me to tell you the price at Penn? Is that, yeah? So
That'd be a good start.
I think it's roughly $4,200 per patient. And then we're trying to get the Stryker 1788. We got a quote for $160,000 for the Stryker 1788. But I think, of course, those things always get negotiated out, and there's leasing plans, and every supply chain in every hospital can talk about that. You do get, and I don't quote me on this, but I think you get roughly 60% back from the insurance company for the tracer, is my understanding. I don't know. We're just getting the supply chain issues sorted out at our own hospital, but I think that there's some, there's some ways to get reimbursement. The other thing is, one of the things we've looked into is getting billing done, because if we infuse it down in the infusion suite, somebody's supposed to get back to me on that. We're not clear if you infuse it the day before, if you can get a separate reimbursement, or if there's I think if you do it the day of, you cannot, because of some global billing, but I think if you do it the day before, you can. So the hospital right now prefers we do it the day before. But again, all this is being worked out right now. We don't have all the details. And the camera right now is just 1788.
Great, thank you. We have a question in the chat. Have you used Cytolux to identify nodal spread?
Yeah, so we published on this a few times. There's a pretty high false positive rate right now for this, and we weren't not exactly sure why. There's two theories. One believe that either the tracer is going to the lesion, and then it is leaking out, passively going through the lymphatic channels, and then draining into the first draining lymph node. So that's theory number one. Theory number two is that the tracer also gets chewed up by macrophages. They may be either chewing it up in the tumor and then cycling to the first draining lymph node, or they may be passively draining and being taken up by the macrophages in the lymph nodes. So it hasn't worked great for lymph nodes. And so we would be cautious to say this is good for identifying metastatic disease to the lymph nodes. And actually, I think potentially your antibody that you're working on might be better for that, because it's a little bit more targeted for that specific receptor, which would not be present should not be present on a normal lymphocyte. So I would think EGFR is for that may solve that problem, but the future will reveal that.
You mentioned getting the camera angle just right, and we saw some of the fluorescence as you were moving the camera in towards the nodule. How easy do you think this is to learn for surgeons?
Oh, I think it's pretty fast, actually. It's really intuitive. I mean, I don't think I'm exaggerating. I think really within 3 to 5 cases you get it down. It's fluorescing or not fluorescing. And I wouldn't be, the one suggestion if you're starting is don't do a lot of cases with people initially who have really bad smokers' lungs with a lot of granulomas and a lot of sort of charcoaly lungs with a lot of anthracosis because though the black isn't great for the fluorescence, it's better. The best case is sort of the young non-smoker woman who comes in who's got these ground glass opacities that you're going to get a very crisp image on in those situations.
All right, we have another question in the chat. Thank you, Matthew. Will you use Cytolux on every lung cancer case or be more selective?
Yeah, we're being pretty selective. I mean, you could use it for every case, but there's a number of, our thought process is the following. So, for example, if a patient comes in with a stage 1 routine 1.2 centimeter ground glass opacity, solid components a centimeter, and it's very central, and you're going to do a low, and the chance that that person has, metastatic disease is almost 0. And you had serial CAT scans, you have serial 1 millimeter CAT scans over 2 years. This is sort of the typical patient we see, right? You've been following them, nothing. You're probably not going to see anything else. And because of hospital costs and, we probably would not inject that patient. You get a patient though, on the other extreme, right, is you get somebody who's got multifocal disease. And they have 1 lesion for sure, and they may have other lesions. And you even see on the other side, they have some wispy stuff. And we didn't go into this because we were specifically talking about localization. There's a concept of synchronous disease. So in the randomized clinical trial, don't quote me, but I think there was an 8 to 10% likelihood of finding a synchronous cancer. What was really interesting in the phase 3 study, which was done, was 7 out of those 8 lesions, if I recall, were in a different lobe. So and all 7 of those turned out to be a stage 1 lung adenocarcinoma. So that's the other extreme. I mean, if there's a high suspicion going into this that you're going to get other lesions, synchronous lesions, then that's a value. Another value is, let's pretend you're going to do a segment. So you're committed, you're going to do a segment, you're not going to do a lobe. It's a lingular lesion, but it's going to be a tight segment. Like it's really close. It's not right at the tip, but it's close between the left upper lobe proper and the lingula. Then you'll use it because it's really nice in the back table to get a quick margin assessment instead of having to wait for pathology. Because once you take it out on the back table and you can control the light, you don't have the motion that I showed you on that wedge. I mean, you can tell exactly where it is. So that's an example where you might want to use Cytolux. So you got to balance all the aspects. Just another quick, let's pretend you have a 3 or 4 centimeter central lung squamous cell. You're probably just doing a lobe, and you're gonna have a negative margin. Again, I wouldn't probably spend the money on that.
All right, thank you so much to our speakers and Dr. Rosenberg for co-moderating with me. We've enjoyed this webinar, and I will turn it back over to our STS staff.
Yeah, thank you, everyone.
Thank you so much to our moderators and speakers for your participation and insights. Please join us for the next STS webinar on Thursday, December 7th, Early Career Journey, the Business of Medicine, how to successfully transition from training to practice. Details are on STS.org, but you can also use the QR code. Join us for part 2 of the sponsored AstraZeneca webinar series on Thursday, December 14th. Scan the QR code to learn more. Registration is open now. Join us for the Latin Hearts Rounds webinar series, Rounds on a Patient with Ascending Aortic Aneurysm and Arch Involvement, on Friday, December 15th. You can also scan the QR code to learn more. So we have a really full last month of December webinar series. So please join us. And then we just posted the latest 8 in 8 series presentation, Abdominal Complications After Cardiac Surgery, How Sweet It Isn't, Perioperative Cabbage Diabetes Management. Oh, sorry, I mixed those up. Perioperative Cabbage Diabetes Management. Again, please visit sts.org, scan the code, and thank you so much for participating.